Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
Over the past 2 years, some of our most popular episodes have been about how to improve your treatment acceptance, from the financial discussion to how to handle objections to how to organize your practice to maximize treatment acceptance. It's also the subject we get the most listener questions about. And I understand why it's a hot subject. You're not going to produce what your patient doesn't accept. And improving treatment acceptance is the fastest and most sustainable way to increase collections in your practice. And of course, in the long run, better treatment acceptance potentially equals better oral health for your patients. So it's sort of a win-win across the boards. So what I want to do for this week's episode, I want to revisit the subject of case acceptance or treatment acceptance, but rather than focusing on one aspect of it, such as finance, I want to discuss the whole package from start to finish. In other words, what are some key actions that you can begin doing right now? And by right now, I mean right after you finish listening to this episode to see immediate improvement in your treatment acceptance rate. My name is Jeff Bloomberg and I'm your host. And there's a lot to talk about on this subject. For that matter, the average MGE client or office manager will spend 20 to 21 days, including treatment coordinators for that matter, on the MGE Power Program, training on the subject of communication and case acceptance, or what we call sales. So I obviously don't have that long, although I probably could talk that long if I were challenged to, if you were to ask my wife. But I am going to get into the basics. So obviously I'm not going to make you an expert, or give you enough information to become an expert in just a podcast. But we are going to go over some very critical fundamentals that we go over with every MGE client to start seeing an immediate change the second you finish listening. And as with anything we go over on the podcast, we're giving you information. It is up to you to decide how you want to use that information, if you want to use that information or not. It's up to you. I'm a firm believer that everybody is responsible for their own condition. So I just suggest you use your due diligence, or use your better judgment, rather is probably a better way of saying it, to decide what you want to implement, what you're comfortable implementing based on what I'm going to cover with you today. All right, so we're talking about the subject from start to finish. So where would we start? Where does treatment acceptance start? Well, the first place it really starts is, because we're talking to the doctor now about this, okay? I'm not talking to the treatment coordinator with regards to this specifically. We're talking about the doctor. It starts with the doctor's attitude. And this isn't just, a mindset, I'm going to look in the mirror and feel a certain way today, but it's your actual attitude towards what type of a practice you are creating. Talked about in prior episodes how you have 3 big jobs in your practice if you're a doctor owner. You're the doctor, you're the owner/executive, and you're a salesperson. Those are your major jobs that you have to fulfill and get the results from, just like you would expect a scheduler to get an expected result. You're supposed to produce a result on those 3 specific jobs. So let's take a look at the doctor job for a second, because you could boil the doctor job just down to clinical excellence. How did you prep that crown, or did you do a good job on this procedure? And of course, that's part of that doctor job. But there's another aspect of the doctor job which takes you away from just one particular thing. We're not just talking about a specific procedure, but we're looking at the patient as a whole. What is your job with relation to your patients? And obviously, this is going to differ based on the doctor you're speaking to. We have the basic, you're supposed to restore health, function, and aesthetic to all of your patients. You're supposed to make your patients well, or as well as they can potentially be. That's your job. So you'll notice that if that's your job, you're just looking at every patient through that lens. How do I make this patient, restore function, health, and aesthetic to this patient? How do I do it with this patient? How do I do it with this patient? Because that is your mission. That's what you're there for. Not just to do each of the procedures involved in that well, but the entire package, okay? So if that's your job with each and every single patient, you'll notice certain things don't jibe with that. It's not, I'm going to restore health, function, and aesthetic based on what insurance will pay for. That's really not part of the doctor job description. The doctor job description does not take insurance into account, because that is really immaterial. Whether the person has coverage or not doesn't mean that you wouldn't want to restore their health, function, aesthetic, or make that patient well. Let me give you an analogy, and it's really not comparing apples to apples, but sometimes I find it helpful if you take it outside. You get so stuck into what you're doing. It's hard to think outside the box. But let me give you an analogy from something completely different. Let's say you're an MGE client and you're on the MGE Power Program, which is executive and sales training for the doctor and the office manager. And, I had a lot more individual client interaction earlier in the history of our company before we grew. So let's say I'm meeting with a client and they're telling me what's going on in their practice and they're explaining to me what they need. Their office manager is doing a good job and they're doing well and they're really expanding a lot. And it's obvious to me based on what's happening, they're missing out on case acceptance. They need a treatment coordinator. So, but I know that this person doesn't like buying things. Let's say I'm thinking that, or, they've complained about this or they're building a new this or that or whatever. So I know that they may have some financial pressures. So the fact that they have those financial pressures or all those other things that are going on is really not my problem as the technician, which is really sort of the hat you're wearing as the doctor. Okay. So the technician, I have to look at, here's this practice. They're missing out on 50% of potential case acceptance because they don't have enough time to spend with patients. And their office manager is bogged down into being the treatment coordinator all the time. So no one's watching the store while it's working. So that's really not my problem that the doctor doesn't like to buy things or is building a new, addition to the practice. Meaning I'm not trying to be heartless about that. What I'm saying is from my hat as the technician, I have to look at what's best for this person. What is the best thing to do to achieve what this person wants to achieve? So I would tell them, well, you need a treatment coordinator and you need to train one, and that, that could cost you something. Now, when it comes time to figuring out how they're going to pay for it and paying for it, well, that's the salesperson's job. Now, if I was also being the salesperson, which you are as the doctor owner, then you sort of have to take one hat off and put the other hat on, and now you're into the sales thing, and you're working that out. Maybe they're putting, in my case, maybe they're putting a down payment down to figure this out or whatever. But that none of the fact that there's financial pressures or other thing, or in the case of when you're dealing with patients that they like only doing what insurance covers, none of that changes the fact that they need whatever treatment that they need. And what can happen is you can get so beaten down, maybe this was never on your radar when you're in dental school that you're going to have to sit down with patients and talk money and get into what insurance covers or things of that nature. That was maybe never on your radar. And, but that has no bearing on the fact that they need what they need. So, you can get beaten down by it. I've seen doctors who get so beaten down by it that they get to the point where they're only doing what insurance covers, because they just don't want to get into an argument with the patient, or they're convinced that's what all patients want, even though it was just, 4 out of the last 20 who told them that. They're convinced everybody thinks that way. And they get to the point where they don't even tell patients what they need. I've seen that. I've talked about that on prior episodes. You got a new patient and they need $15,000 worth of treatment, and you're so worried about, as the technician, as the doctor, this is what this person needs. You're comfortable that from a treatment perspective, it's what they need. And that between either yourself or between you and a specialist, you could excellently execute that treatment and bring about a better condition in their oral health. This, okay? But then you start to, adopt considerations. Well, if I tell them this, they're going to be all freaked out because they just walked into my office for the first time. They're a new patient. And they're going to think that I just want their money. All of these things. None of those things have any bearing whatsoever on what they actually need. Okay. So from the doctor's perspective, from your attitude as the doctor, you have to look at what are you all about? What do you really want to do? If your game is, I want to get my patients healthy, then that should be the viewpoint you're approaching each and every single patient with, regardless of their financial qualifications. And look, not everybody's going to do it. Some people might get pissed off with you for telling them that they need a lot of treatment. But, if you think you're going to make everybody happy in your life, you're going to be in, and you've probably already been in for a humongous surprise. That's not what happens. Okay. So why be afraid? They came to you because you're the expert. Why be afraid to tell them what you found? So that to me is the biggest thing. That's the biggest thing, because I've seen it. I've met with so many, between clients, new clients over the years when you've been doing something long enough. Number one, it means you're old. But number two, it means you've seen just about everything. And I've seen it where people won't say what someone needs, or they try, I'm going to tell them they need perio treatment today so that when they come in next time, I can tell them about all the restorative treatment they need so they don't think that I just want all their money. Who cares about any of that? You're the doctor. That's why they're there. Your job is to get them well. Okay. So it begins with the correct attitude. What insurance covers or does not cover has zero bearing. Now, is everybody going to do everything you tell them? No. Probably not. I've yet to see that, but that's fine. They at least know, don't they? And that you've made it real clear to them. Will a lot of people do it? Absolutely. Will a lot of people appreciate the fact that you were completely forthright with them and you weren't worried about, hurting their feelings? Yes, they actually will. But because that's why they're there. If I go see an expert for something, I'm seeing them because of their expertise. That's the reason I'm there. Okay. So you have to be comfortable, in your own skin, and you have to know what type of a practice you're trying to create. Otherwise, you see things like I mentioned, I've seen people who, we're only doing what insurance covers and they'll leave active disease. I've also seen on the flip side, where a patient could do the treatment that they need, but they're insistent upon maintaining an active disease state and the doctor just won't treat them at all, which, if that's what they want to do, I'm not against that. You have to be able to stand on your own 2 feet and keep your integrity as the doctor. And that's how you sleep at night. So it starts with your attitude, and it actually starts to make your profession fun because then you're doing what you went to school for in the first place. All right. So that's where sales begins. It begins with you and your attitude. Now, beyond specific communication and closing techniques, which I'll talk a little bit about, the next thing you need in order to improve treatment acceptance in your practice is a process. And what do I mean by a process? Well, you have a process for a lot of things that you do in your practice. As a matter of fact, you'll see things that go well normally have a pretty well grooved in process. And think with this concept of grooved in for a second. You can imagine like a wagon or a cart going down a dirt road. We find this not we, but archaeologists find this. They'll find, in a brick road, they'll find tracks that wagons have been going along for hundreds of years. Well, that's a groove. So the wagons don't have to figure out what part of the road to drive on. They just drop their wheels into the groove. So you want to groove a practice in with regards to sales. You have grooved in practices in your office, such as if I were to call your practice and let's say patient a record and I need to get my crowns done. There's a process where I go on the schedule, how long I'm scheduled for, what my payment arrangements might need to be, how long the procedure is going to be, how the room is going to be set up, what labs you might use. That's a process. No one has to think about it. The whole team is aware of it. So it just sort of happens. All right. At least we hope, right? So with regards to sales, you need the same thing. You need a process. And if we take a look at the process, I can get into the new patient side of it as far as the phones or whatever. I'm not going to in this case. We'll start when the patient's in the practice. But the process from the examination to the presentation to the financial arrangements to how they're scheduled needs to be fully stated, fully understood, and agreed upon. And everybody has to be on board within the practice. So your hygienist knows how this works. Your dental assistant knows how this works. The treatment coordinator knows how this works. And how should it work? It should work the way that you want it to work. Okay. I'm going to give you some suggestions, but then you should take those and go, well, this is how I want it in my office. This is what works for me. You make that known to everybody. It might be a staff meeting. You might record something on your iPhone and have somebody type it up, but this is how we do it in my practice. So everybody's aware of it. The longer you do that process and there is no variance, the better it will be grooved in because it becomes second nature. It's a funny thing about organizations, just something I've observed over the years. If you have a meeting at a certain time, and I've mentioned this with like executive meetings or staff meetings or morning production meetings. If you have a meeting at a certain time and you do it consistently for a long period of time, people are used to having a meeting versus not having a meeting. So let's say you cancel the meeting at the last minute, you'll still find people showing up at the meeting spot at the exact time they were supposed to be there because they're almost, I hate to use the word program, but they're grooved in, okay, to doing that. So you have to have that same concept with relation to your process. It should just be continuously done so that when it's done wrong, like let's say you have a new employee, new treatment coordinator, new scheduler, the rest of the people who are part of that process can see that real fast because they're so used to being done right, okay? So we have exam, presentation, financial arrangements. So let's talk about the exam for a second. So with relation to your exam, we'll just say let's say it's a new patient initial exam, which every road should lead to at some point with a new patient. Even with an emergency patient, they should be brought back in for an initial, right? And you have your recall exams too. But let's talk about an exam. You're meeting a new patient for the first time. The clinical steps that you go through are completely 1000% up to you. That is up to you as the doctor, how you want it done in your practice. One thing I advise every MGE client to do is if you have a new patient exam sequence or procedure, first I do this, then I do that, however you do it, you should put it in writing. Number one, that everybody knows how you like to do it, including your dental assistant if they're with you on it, or the hygienist if you're seeing new patients in hygiene. But number two, if you're expanding, you'll eventually add an associate doctor someday. Well, wouldn't that be easy to just say, this is how I do my new patient exam procedure? It adds some stability because then they know exactly what you want when they walk into the room, and it becomes a policy in your practice. Now, but let's talk about the non-clinical aspects of the exam, because this is this opportunity where we're meeting this person for the first time. So what are some things you're going to want to know? And you probably do a lot of this, but I'm going to throw it out there because I've seen some people that don't. So you've just met this person. One of the first things you're going to want to establish is, chief complaint, obviously, but also what is it that they would like you to do for them? How can you help them today? Let them talk. Well, I don't like how my teeth are crooked, or, this tooth over here hurts, or nothing. I'm very happy with my teeth, right? There's a reason that we suggest you do this. Number one, you're finding the patient's there for a reason. We should find out what this reason is before we start looking in their mouth. Okay. Number one. Number two, it gives you an opportunity to assess this patient's frame of mind. Okay. If they tell you, well, no, my teeth are happy, I'm just here to get them clean today, and then you do your exam and you find out that they're a bit of a mess, that tells you that you're going to be in for an interesting bumpy ride when you have to tell them that they need all this treatment. All right. In which case there's a couple things I'd suggest with regards to that. But you want to assess their frame of mind with relation to what they want, what they're trying to achieve, why they're there. Okay. They are there rather, so that you can, best service them and turn them into a long-term patient. So if you assess their frame of mind, then you would do whatever you'd normally do during an exam. And that's obviously up to you. Now, if you're going to be charting while you're doing your examination and you're going to be using tooth numbers and whatnot, the only suggestion I'd make here is use abbreviations. Obviously, it's faster, number one. Number two, if you start tossing procedure names out with relation to tooth numbers, once you start saying procedure names, root canal on number 3, you've just begun the sales process, which we don't want to do yet. We need a crown over here. This crown has an open margin. I wouldn't get into that stuff. Have an abbreviation procedure. CR on 3, RCT on 6. It should just be simple. And you tell the patient beforehand, look, just for shorthand purposes, I use abbreviations when I'm doing when I'm looking in your mouth. So don't worry about it. I'll explain it all to you once we're done. So you go ahead and you do your thing. Avoid using terminology because it begins the sales process. And then you finish your examination. At that point, you now have to assess what you're looking at. Because one of the key things you're going to need, and if you've been listening to the podcast for a while or watched any of our videos on YouTube, you've heard this before. If it's a larger treatment plan, more than a crown or whatever, you're probably going to need some time to explain it. So let's look at where you are now. You've done your exam. You've finished your charting. You're ready to go. You know exactly what's happening. You're formulating a treatment plan in your mind, or you've already even just put it into the computer terminal. So that's when you have to stop, take a deep breath, and assess. You take a look at the time. Maybe you're doing a chair, the 2 chairs over, you just numbed a patient up to go do a long procedure that you're not going to be able to pop out of. Or maybe this patient is only scheduled for another 5 minutes and they have to be out of there to get back to work. Well, with a substantial treatment plan, you need time to present the treatment plan. So I would not recommend presenting it right then and there because you're probably not going to close it. And I've said this before, but I'll give you a thought experiment. Again, nothing wrong with saying something twice, but if this treatment plan is, let's say $8,000 and this patient makes $80,000 a year, you're essentially asking them for a 10th of their yearly income. The fact that they can finance it is immaterial. It's still a 10th of their yearly income. That's, it's relative to people. You talk to somebody who's a NFL star who's making $80 million a year, $8,000 might be like a parking ticket. But to somebody else, that's someone making 80,000, it's 1/10 of their income. If they're making 40, that's 20%. So you have to take a look at, you need time to be able to explain it. You need time to answer questions. And the most important thing here in all of this is that this patient actually gets the treatment they need. That's the conditions we want to create. We don't want to create any conditions that would possibly stop the patient from getting the treatment they need because we explained it too quickly. We didn't have time to answer questions and so on. So you got a decision to make. if you have time to present and they have time, because you don't want them distracted. Oh, sure, I have 10 minutes, and you feel like you can squeeze it. And then they're like, that's a great excuse I could give you. If I didn't want to hear anymore, I could just say, hey, I got to get back to work, right? But if they have time and you have time, absolutely present the treatment plan now. And I obviously prefer that. They're there. They don't have to come back. That's ideal. But let's say they don't have time, or you don't have time, or both. Now, what I would not say, somebody asked me about this, should I say, I don't have time to tell you what your treatment plan is today? No, that just sounds horrible. Please don't say that, okay? What would you say? You'd bring them back for a consultation appointment. So it might be, Joe, here's what I'd like to do. I want to go over what I found with you today, and I want to spend some time on this. I'm going to need about 20, 30 minutes. Okay. And we're going to sit down. It's just me and you. I'm going to explain exactly what I found and exactly what we need to do about it to improve it. Okay. Or to fix it, or however you want to say it. And they may press you, well, doctor, can't you tell me what you found? I want to sit, and you could actually start this off this way. You could say, look, I'm going to review everything that I found today and come up with an exact treatment plan for you and have you back to be able to present it. Like, in other words, you're stalling them because you want to spend some time studying their x-rays and looking at what, maybe you poured up models, who knows, looking at their scan. You want to make sure that you have the exact treatment plan that's right for them. In other words, you're buying yourself some time, not because you're too busy, okay, but it's important that you actually give yourself an opportunity to make sure that you're giving what's right for them. If they press you again, you could say, look, I want to do what's right for you. Just give me a little bit of time. I can see you back in 1 to 3 days, and we'll go over this fully. You have my undivided attention. I'm going to be there with you 20, 30 minutes, answer all your questions, etc. Now, obviously, there's always a risk when you send this patient off and you bring them back. There's a bigger risk if you send them off telling them they need XYZ procedure and try to bring them back. They're going to just start shopping on the internet. I wouldn't get into the procedures until you bring them back. That's just my 2 cents. You have to do what is real to you. And ideally, if you could present it that day, present it that day. The question is, when do you bring them back? Now, you may have time baked into your schedule for consultations. And, you hear consultations, you always think of like a full mouth rehab or an all on 4 case or an all on X case or whatever. A consultation really is a set period of time where you're going to have an opportunity to explain everything to the patient so they fully understand it and answer any of their questions. And again, remember, $8,000 case, $80,000 of your income, that's 1/10 of their income. That takes time to decide. That's not something someone's going to decide in 5 minutes. So when you bring a person back for a consultation, always bring them back no longer than 3 days from now, because the longer you wait, the better chance they're going to blow off the appointment or they're going to miss. And then you have to decide where on your schedule you're putting consultations. I've made suggestions where you might want to do them first thing in the morning or first thing after lunch. First thing in the morning, you could do 2 20-minute consultations, which has a lot of benefits. Number 1, you're not in with another patient yet. Number 2, if you're doing big procedures in the morning, if one of those procedures cancels at the last minute, there's always a chance you could keep one of those patients you're doing a consultation for to stay that day. Right? And first thing after lunch is great because even if you work a little bit through lunch, you're starting after lunch completely distraction free, and you can give your patient your full attention. Okay. So again, present that day if you can. If you can't present that day, bring them back for a consultation. So, and what size case justifies a consultation? I leave that to you. I mean, there are obviously some no-brainers. If they need 2, 3 surface composites, that's not a consultation. You need some fillings. Go talk to the front. Not a big deal. But you have to use your judgment with regards to a patient. 3, 4 crowns might justify a consultation, especially, if they're $1,200 a crown's a $5,000 case. And you spend 20 minutes of your life, but then you make sure this patient's actually getting what they need and your schedule is more productive. So let's say you're bringing somebody back. You're not presenting that day. You're bringing them back. The last thing I would suggest is the patient is most likely to listen to the doctor. That's who a patient is most apt to listen to. If you don't believe me, ask your staff. So if you're a little bit involved in scheduling that consultation, it's not necessarily a bad idea. Let's say you're in the room with your dental assistant and you go, Joe, I'm going to bring you back for a consultation. I want to review your my notes and your x-rays or whatever to come up with the exact treatment plan and plan of attack here. I'd like to see you back for a consultation. Let's say your dental assistant's there. You might say, Sally, when is my next consultation appointment? Well, we have one at 8:10 day after tomorrow, doctor. And Joe, does that work? 8:10 day after tomorrow? Yeah, I could do that. Good. All right, we'll see you at 8:10. This gives you a little bit more control over when you're going to have these opportunities to present, or like I said, present it that day if you have adequate time, 20, 30 minutes. And that again is up to your judgment. A really super large case, 20, 30 minutes might not cut it. Okay. So let's say you're actually doing the presentation. So the treatment presentation itself requires, a couple of skill sets. Obviously, you've used your doctor skill set to diagnose the treatment that the patient needs. All right. But it also requires a little bit of the sales skill set, meaning you have to be willing to communicate. If you find that you have trouble communicating with people, or you feel uncomfortable communicating with people, or uncomfortable about certain aspects of it, you probably need some individual training in that area, which we can help you with. Okay. But, if you're backed off, I've talked to doctors. I remember bringing my wife to an ENT once, and he looked at the ground the entire time. Great ENT. Couldn't talk to us in the face. Like, that's bad if you're trying to sell, okay, which is one of your jobs. So what are the 6 things we want to do during a consult appointment? So you've got the patient, you've sat down, you've made whatever small talk you've made. You're going to go over, number 1, what you found. In other words, what's wrong. Number 2, you're going to find out, you're going to discuss the consequences of what you found. You're missing a tooth here. Well, obviously they would know that too. But if we don't fix this, this is what potentially could happen. Number 3, you're going to want to go over how you want to fix it, what treatment is involved in fixing it, and really make sure that they understand all of this treatment. You also don't want to use a bunch of terminology they're not going to get. There are no periapical see this periapical radiolucency here? You don't want to get into that type of stuff. Wouldn't even use the word abscess. A lot of people don't know that an abscess is an infection. Use lingo that everybody uses on a day-to-day basis. I'm not saying your patients aren't smart, but they're not dentists. So use language that is accessible to everybody, like non-medical personnel. And if you have to use a medical term, then explain it. Here's what a crown is. Maybe they don't know what a crown is. You might have an old lab case. You could just show them, look, see, that's a crown. Or what's an implant? Pull an implant out. See, that's an implant. Give them an understanding of what it is that you are trying to do. So assuming we've got it to where they understand, here's what's wrong, why it's a problem, make it very clear that they can ask as many questions as they want. Well, do I really have to fix that? Why is that a problem that I have an open margin there? Right? If you're going to tell them open margin, obviously explain what that means. But why is that a big deal? Well, the decay and the bacteria can get in there. Like, you want to explain this fully. Oh, okay. I understand. So you want to make sure they understand the first 3 things you've covered. What's wrong, what the consequences are, and how you want to fix it. The next question is, do they want it? So look, how does this seem? Do you have any questions about this? Does this make sense to you? Obviously, the cost question is going to come up pretty soon if it hasn't come up already, which I'll get into here in a second. But, well, yeah, I want it, but I don't know how much it costs. Okay, fine. Then you can get into cost. Or, I don't know if I really need to fix that tooth. Well, you need to go back into steps 1 through 3 again. I wouldn't get into cost until you're pretty sure the patient is interested in doing the treatment plan that you're recommending. Okay. Now, it might be, and the funny thing about cost, I have clients that mention cost right from the beginning. Well, this treatment plan is going to cost you about $10,000. Let me explain why. That's fine, right? Or they get into cost at the end. The key important thing with regards to cost is if I'm talking to somebody about buying something and we're arguing about cost, we're going back and forth, well, then what do I know? I know most likely they don't want it. So I might even ask them again, well, look, do you really want to do this? Well, I don't know. If there's any, I don't know, or they kind of think for a second, I'm going to drop the money discussion at that point. Because if this person, why am I arguing about money for something somebody isn't even sure they want? That's just stupid. Okay. So if I'm getting into an argument about whether they want to do it, whether they want to wait, blah, 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 I'm going to, and it's part of the financial discussion, I'm dropping it. I'm going right back into whatever it is that I'm talking to them about buying in the first place and showing them why they need it. Okay. But let's assume they go, yeah, doc, this makes sense. I'm a bit worried about how much this is going to cost, but obviously I need this. So with that in mind, let's get into this cost concept for a second. So let's say you've gone through all the way to the end, the patient wants it, and now you got to talk money. So I have sort of a minimum requirement that I give our clients, and then I go, this is the better way to do it once you feel comfortable doing it. Because, look, the average person coming in here, I would say the majority of the average doctors coming into MGE are not comfortable discussing fees with patients. They've been told over the years it's bad, it's going to make them look bad, etc. That's all bogus. Okay. Someone's going to give you a hard time for everything. There's somebody who would probably give you a hard time for saving puppies. Okay. There's always going to be people who are just like that. All right. And if you take a look at it, this is the funny thing. If you take a look at the patients that have given you a hard time in the past, you just want my money or you're just interested in this. How many patients have actually done that? It's probably a handful. But then I want you to compare that against the number of patients you've seen in that same period. I had somebody do this in a seminar a few months ago. Okay, so how many patients did that to you? 4. How many patients have you seen in that same period? Those 4 people did that to you. 500. I mean, that's pretty good. That's less than 1%, isn't it? So there's always going to be people who give you a hard time. They're not fun. Maybe they don't belong in your practice, and that's okay too. All right. But here's the minimum I would do. You've gone through the treatment plan. You've explained what they need. They want it. Your treatment coordinator, I would recommend that they're there with you throughout the entire presentation, maybe with a smaller case or maybe where you have a treatment coordinator where you have a great working relationship. You've been working together for a long time and they can kind of just pick up where you left off and they know how you would handle certain questions. You could always do it on your own and bring them to the treatment coordinator after, but it usually works best, especially with a larger case. And by larger, I mean, it could be like $6,000, $8,000, $10,000 or more, that the treatment coordinator is there. So you get to the end, the minimum would be, okay, so this treatment plan is going to cost about $8,000 and we expect your insurance to pay about $1,500. So then the patient might say any number of things, wow, that's a lot of money, or wow, that's a lot. I have no idea how I'm going to pay for that, or whatever they may say, or do you take payment plans? At that point, this is your minimum, folks. Like you would never do less than this. You can say, listen, I completely understand. Here's what we're going to do. John, our treatment coordinator, who they've met, John's been in the room. They aren't just sitting there nondescript, with some random dude sitting in the room. I'm going to have you and John discuss that. He has lots of different ways you can figure this out, but you understand why you need it, right? Do you have any other questions? Okay, good. I'll leave you with John and you guys can figure it out. I wouldn't say it like that, but I'll leave you with John and he'll show you how we can make this work. All right. That would be the minimum. Don't say figure it out. That's the minimum. What would I recommend instead? It would be, it's $8,000. We expect your insurance to pay $1,500, or let's say they don't have insurance. It's $8,000. Wow, that's a lot of money. Completely understand. Now, how would you normally take care of something like that? How would you normally pay for something like that? Whatever you feel more comfortable saying. Well, I don't know. I mean, I guess I could put it on a credit card. Well, we do have a prepaid discount that we offer here in the office. If you pay today, you could save 5% or $400. Or, they may go, well, I could put it on a Visa. Okay, great. Or they may say, listen, I'm going to have to do a payment plan, in which case you have whatever patient financing solutions you have in the practice. Well, we can do a payment plan through this, that, and the other. You might ask how much they can pay per month, because that may help you figure out which payment plan is going to be best for them. Maybe they can't pay enough per month to qualify for 2-year financing, no interest financing. And then your treatment coordinator knows what the plan is, and then they're going to go off and figure it out with them. Maybe you're presenting this in the consult room and you leave the treatment coordinator in the room, or maybe you're in the operatory and the treatment coordinator takes them off to their office. But ideally, you're helping them figure it out. Not really helping them figure it out, but you're getting them to start figuring it out. And I did a whole episode on this with patient financing. And like I said, we love patient financing companies. We work with quite a few. Sometimes things that people get way too eager to use them when the patient could just pay. How would you take care of something like this? Well, could I put it on my American Express card? Absolutely. Why would I get into patient financing at that point? I'm going to pay 3% for American Express or 14.99 for something else. You see? So, and it's just a done deal at that point. So you have to use your judgment in this regard as far as how you're going to approach this. But what I would expect at minimum as the doctor is you have to tell the patient how much things cost, because this goes right back to a patient is most likely to listen to you, the doctor. Okay. Now, the last thing you might want to do before you leave the room, even though the financial arrangements aren't done yet and the patient can't go on your schedule yet, I would affirm the schedule a little bit to ensure that your productive bits of your schedule get filled. So let's say you've structured your office schedule so that you're doing primary procedures in the morning. Okay. Well, then what you might do at the end of this, the patient wants to put it on a credit card or they're going to do a payment plan. Look, it's not done yet, but you might just say, this is awesome. I'm going to let you work with John. You guys will get all the paperwork done. Now, I only do these procedures in the morning. John, when is the next available time I have for this procedure? You're asking your treatment coordinator. We have day after tomorrow at 10, doctor. And you turn to the patient. You go, would 10 o'clock day after tomorrow work? They'll say yes or no. Yes, that would work. Excellent. Well, look, I'll let you go do the paperwork with John. I will see you 10 o'clock on, whatever day it is, Thursday morning. Looking forward to it. Then you've at least, again, put a little bit of control in on the productive bits of your schedule. Now, let's talk about objections for a second, because objections are going to come up during this whole discussion. All right. Now, the only two things I would say with objections are this. Number one, if the person doesn't want the treatment plan, doesn't understand the treatment plan, because remember, the thing you're going to understand best about all of this is the cost, because we're involved, everything in our life has a cost associated with it. So when you're discussing money, they understand that, but they may not understand why it's important that they get this crown done or they get this procedure done or that procedure. They didn't even understand the procedure. So the first thing I look at with regards to objections is, does the person actually understand what it is I'm trying to do or get them to do? Assuming they do, and they're just throwing objections out there, well, then I have to take a look at how am I going to handle those objections. So there are two types of objections that you might get. Really two categories of objection. One would be a real objection, and the other would be a faulty objection. It doesn't mean the patient's faulty or whatever, but what a faulty objection is, it's not the real reason they're giving you. It's just a way to sort of blow you off. It's essentially sales resistance. So what are the conditions of a faulty objection? I'll start there and then I'll get into the real one. Number one, a faulty objection changes pretty regularly, and the patient is not very communicative about it. So you're talking to me, you tell me what treatment I need, and I say, oh, and you tell me the cost. Oh, doctor, this sounds great, but I'm very busy. And then you talk to me some more. Wow, there's no way I could afford that. You notice I'm not telling you why I can't afford it or what my financial condition is that's precluding me from doing it. I'm just giving you that. Then you talk some more. Oh, I'm going to have to, check with work to make sure I can take the time off. And then it's almost like changing a channel, and I'm not very communicative. It's sales resistant. It's a way to get you to stop talking to me. That's a faulty objection. And with those, you listen to them, you go through your process, make sure they understand what they need. They tell you the objection, you understand it, and, you answer any questions. And then you kind of just dive right back into whatever it is you were doing, as far as making sure they understand the treatment plan, right? Assuming if you're into the cost at that point, you're getting these, you just go right back into the treatment plan. I would dump costs if the patient doesn't want it. Now, what's a real objection? Real objection has three basic conditions. Number one, it seems real. Like I have to talk to my wife. Let's say you say it to me, I've talked to my wife. Well, Jeff, do you want to do this treatment plan? Absolutely. So if we're up to you, you would just do this right now. Totally. All right, then why don't you just do it? Well, no, doc, listen, I have to talk to my wife. We made an agreement. If we're ever spending this much money, we always have a discussion about it before I do it. So I have to talk to her. Well, what would happen if you just did it? I would be sleeping in the yard. Okay. So that's real. And if you were to try to push me again, listen, I really got to talk to my wife. So I'm not changing the channel on that objection. You see, it's right there, and I'm fairly communicative about it. And so again, it's real. I'm in communication, and it's not changing. Let's say you lay it out. It's a $12,000 treatment plan. I go, doctor, I'd love to do this right now, but I'm right in the middle of getting a construction loan for a remodel we're doing in the house, and my banker told me not to apply for any credit. Now, this should be closed in the next 3 weeks, at which point I'm more than happy to. I can give you like a $500 down payment to reserve my time on the schedule, but I just can't right now because I can't mess up my remodel. Okay, so let's look at that. That seems real, right? And that's legitimate. I mean, I might mess up this loan. Number two, I'm communicative about it. And number three, I'm sticking to it. I'm not changing this. If you were to continue to press me, I'd go right back to that, which I wouldn't necessarily recommend because this is real. So when you see objections, faulty objection, usually what I'm going to do is just tell the person I heard it so they make sure I understood it. And then I'm going to make sure they understand why they need what they need. They really get the treatment, the problem, and the consequences. Real objection, I'm going to listen to and then plan accordingly. I might have to push this case for 3 weeks because the person's going through refinancing, or they're getting a construction loan, or they're doing something, or they have to talk to their spouse. Now, that's kind of a special, unique objection, talking to the spouse. So what you could do if you were bringing a patient back for a consultation, you could ask when you're scheduling if anybody else is involved in healthcare decisions. And, when they make a decision about their health or spending money on their health, and they may say, yeah, I always have to talk to my wife or husband about it. Have them at the consultation. Maybe you have to schedule it at a different time, and I might even go a little further, which I'll tell you in a second, but ideally you want all the decision makers there for the consultation so that doesn't come up at the end, doctor, sounds great, I got to talk to my spouse. Some people are comfortable saying, the patient says I have to talk to my spouse, and you go, good, can you call them real quick? I probably wouldn't do that. That's just my own personal preference, but it's okay. I mean, there's no right or wrong with this, right? You might feel comfortable asking them to do that. I've even done it, or probably what I would do is let's say you went through a whole consultation and then the objection that comes up that the person's sticking to is they have to talk to their spouse about it. Maybe you were doing it same day, so the spouse wasn't there. I'm more of the mind. I'm always a fan of having the spouse on board with doing whatever we're doing, especially, and there's also side benefits to this too, folks. Maybe their spouse isn't a patient. This is a potential new patient for you. But I'm more of a fan of having them on board. I don't want to have this person buy a bunch of services from my business and go home and their husband or wife is all pissed off and now they hate my office. Like, I don't want to do that. I'd rather they were a customer of my business too, right? I want them to be supported in this. I'd like to see the whole family. If I were a doctor, that's where I'd be at. So I might even say something like this. Let's say I've done a consultation. I find out the spouse objection comes up at the end. I might say, listen, here's my only concern. So first I'd ask them probably, well, what do you think they'll say? Oh, they're going to let me do it. I just have to tell them. Well, in that case, fine. Let them go talk to them. Set up a time to follow up. Okay, well, we'll have the treatment coordinator follow up tomorrow. Fine. And you may lose some of these. And that's something I want you to get through your head now. You're not going to close everybody. Not going to happen. Even the best person isn't going to close everybody. So you have to be, if you're closing 30 to 40% of full treatment plans, I'm not talking about closing something, but let's say that patient with 6 crowns, you're not just doing the 2 crowns insurance covers, you're doing all 6. If you're closing 30% of those now, if you can get that up to 50, that has enormous impact on your patients and your practice. Okay. You're not going to close everybody. We get it to 80, you're in a whole new world of not just job satisfaction, but practice revenues and patient health. So you're not going to close everyone. But let's say I've got that situation where, I've asked them, do you have to talk to your wife? They have to talk to their wife. They tell me. And I ask them, what do you think they're going to say? Well, I don't know. I'll try to explain it the best I can. So I'd say something like this. Look, we've spent the last 20, 30 minutes together going over everything about your treatment plan, how much it costs, how long it's going to take, all that stuff. And you're pretty convinced you want to do it. My only concern is you're going to go home and explain this to your spouse and they're going to just fixate on the cost. Because I understand they haven't been here with us for this last 20, 30 minutes. So here's what I'd be more than willing to do. Either we could have it set up where you both come back and I will explain it all over again, or we could set up a Zoom call, assuming Zoom is HIPAA compliant, which I'm not going to go out on a limb and say it is or isn't. I will find out though. And set up a Zoom call and I can explain everything to the both of you so that she understands everything we just went over so that when you go to make a decision, you're both on the same page. To me, it's worth it because number one, again, the most important thing is that the patient gets the treatment. So if I need to make sure their wife understands or husband understands why I'm giving them this treatment plan, I'm going to do that. Number two, as I mentioned, the husband or wife might not be a patient, in which case at the end of the call, I could go, hey, do you have a dentist? No, as a matter of fact, I don't. Well, good. We have a new patient special. We should get you in too. I can get a new patient that way for free. So that's the basic process. We've left it off with where the patient goes off with the treatment coordinator to wrap up financial arrangements and then get onto the schedule. Last few points I would say about this. Number one, if the patient balks when they go off with the treatment coordinator, which, look, I've seen, they tell the doctor yes, they go off with the treatment coordinator. The first thing that says, yeah, I'm not going to do that. Right. Or let's say they need 6 crowns and, well, I only want to do the 2 that insurance covers. What is supposed to happen next? Well, the doctor is the salesperson. The doctor has to be called back into the room. I mean, obviously a treatment coordinator can't decide which 2 teeth we're going to do the crowns on right now because they're not a doctor. It's just wrong. So let's say the doctor instead is in the middle of doing a root canal and can't come back into the room. Because, I've had people ask me this. Well, I'm not going to make the patient wait for a half hour, 45 minutes. I'm going to send them home and say the doctor will call you later to follow up. We'll set up a time. I might make it a little bit less nebulous than that. When's a good time? 5 o'clock. Okay, the doctor has a few minutes at 5. He'll call you or she'll call you. If it's 5-10 minutes, sure, I might have them hang out, cool their jets for a second until the doctor can come back in the room. We don't want to create more inconvenience and ridiculousness by making this person wait forever. So assuming that the financial arrangements go smoothly, patient pays, the last most important thing is, especially if the patient has prepaid or something of that nature, we want this patient on the schedule as quickly as humanly possible. We don't want to see them 2 weeks from now, 3 weeks from now, etc. So you have to make sure that you have time available, because we don't want this patient agreeing to it and then allowing 5 to 10 days to elapse to have all that time for them to, think about why they shouldn't do it, right? We want to just get this done. So get them on the schedule with the same speed with which you're trying to get them to close for doing the treatment, because that's really the whole point of this, is to get them on the schedule and get them through the treatment. That's why we're doing all this, right? So those are the last 2 points I would leave you with regards to that. So that's the basics. Like, that's sort of the beginning to the end of the treatment presentation. Now, look, I didn't get into the communication skills, because that's days of training. I didn't get into every technique on how to really bring home understanding to the patient, just because I can't. But those are some very basic, fundamental actions you could implement right now and see an immediate improvement. Now, a few things I'd recommend that you do. Number one, if you want to see how you're doing with regards to this, your sales, your production, how productive your office is versus how productive it could be, I'd recommend that you, I'll put a link to this on the episode webpage, fill out our production calculator. You add these numbers in, and then you talk to a practice management specialist here at MGE, and they'll give you an idea if you're underproducing or if you're doing fine or if you could do better, etc. They'll kind of give you a little evaluation with regards to that. I would also really, you've dedicated yourself to becoming an excellent clinician. I would dedicate, remember, you have 3 jobs there. You have an executive and you're also a salesperson. I would make sure that you actually know how to sell. There's a few things I could recommend to you in that regard. You could come to MGE's communication and sales seminars. It's 9 days of sales training. I'll put a link to it on the episode webpage. Or if you want to just get started, you can check out our online platform, DDS Success, which also, in addition to staff training and positional training, has sales training for the doctor. So you can learn a bit more right now, in the comfort of your home office, or I wouldn't watch it on a cell phone. That might be difficult. Use something with a bigger screen to start improving your closing ability now. If anything, if after listening to this, if you did anything, if you changed anything today, start telling patients how much their treatment plan costs. Just do that. Start giving them the fee, okay? And you'll see an immediate improvement 9 times out of 10, okay? So that's all I got for you. It was a longer episode this week, but I wanted to have a bit more of a definitive statement on the subject rather than having somebody fish through 5 or 6 episodes to get the data. I really hope this helps. If you have any questions, you can always email me at jeffb@mgeonline.com. Or if you want to find out more about MGE, you can call us at 800-640-1140 or find us online at mgeonline.com. Folks, have a great week, and we'll see you at the next episode.